Thank you, Flavio, for this excellent presentation. And I have hardly ever heard in this clearness the different roles of fibrosis, of urethral sealing, and how much the bladder overactivity or how little bladder overactivity adds to the post-prostatectomy incontinence. As this is overlapping a little bit with my talk on the diagnosis, I think we should discuss the two presentations together. So I will focus now on the post-prostatectomy diagnosis, when, why, what, and how we are going to do this. Unfortunately, there is very little in the guidelines on these things. Most of the guidelines are just taken over from the female incontinence, and as we sitting in this room really know, there is very little parallels to female incontinence. It works pretty much different. So what are the objectives? First of all, we want to measure the severity of incontinence, which again is a question of how do you test, what is the definition. So this is our first problem. And then we need a baseline for the informed consent in the case where we want to do some surgery. And of course, we want to control the continuous success of our therapy. And, which is very important, we need to determine the expectations of each patient so we don't, that they don't ask too much from us. So, the diagnosis also, of course, is the baseline to indicate the correct or specific therapy for each patient. And we have seen from Flavio how the differences are. So we do not have, unfortunately, a method for one fits all, but we really have to see what would fit for which patient. And then, of course, and I think this is maybe one of the most important parts, our diagnostic should keep us away from doing wrongly indicated operations or even contraindications. So this is what we are trying to do with our surgery. Flavio has told you very clearly about the difference between the smooth and the striated muscle. The bladder neck is removed, but still we have a smooth and a striated muscle component, and I would suggest in our thinking of diagnostics and also therapy not to talk about the inner and outer sphincter or internal or external sphincter, but for our understanding it's important to know that we have a smooth muscle component and a striated muscle component which really work very differently. And it makes a lot of sense if you look at our surgery, and this is more a schematic picture. The smooth muscle innervation is what it is at risk during surgery. So mainly what we destroy is this smooth muscle function, the baseline continence. This is what we mainly destroy. Of course, there are other components like fibrosis, etc. That's what we heard. But we hardly ever destroy the pudendal nerve, which innervates the pelvic floor. And that's why the striated muscle function usually is intact. Now, if we look into what those muscles do, this is the characteristics of a smooth muscle contraction. It can contract for a long time without fatigue. So this is what does our baseline continence. And the striated muscle is able to generate high closure pressures. And this is during coughing and moving. But it will fatigue, so even if you train this muscle like Mr. Schwarzenegger or whoever, it will not be able to contract for the whole day. So in some of our, and this is again something you want to look already to the right indication, for some of our procedures that we do, it is only necessary to increase the resistance of the urethra for as little as 10 centimeters of water, because this is all the smooth muscle can do. So if we want to treat this component, this is all we have to do. Now, evaluation, of course, starts with the history. We want to know what type of surgery has been done. We need to know if there is irradiation present, or if there were some transurethral manipulations. Why? Of course, if you ask this, you already should have in your vision that this would be a contraindication for PROACT. This could be a difficulty also for PROACT or also for the advance. So again, when you do your diagnosis, you should have a view on what you are planning later on. Same with the incontinence degree. There is a pad count that we only use the 24-hour pad weight test if we really want to know how incontinent the patient is. And who is using a 24-hour test? And if not, the ones who did not raise their hand, you don't do it because you think it's too difficult for the patient or anything like that. Let me tell you, we did pad count tests and 1 hour tests, and the 24-hour test is really not difficult to do with the patient. You tell him to weigh his diapers, and they will happily do it because they are seeking urotherapy. And I think we should all stick to the 24-hour test, and it is the only one that correlates with results and also with the quality of life score. So the 24-hour test, then the other thing you can ask them, is your urine loss more in the morning or in the afternoon or during coughing? Why would we do this? The patients that lose more in the afternoon than in the morning are the ones who compensate their destroyed smooth muscle with their striated muscle sphincter. And the point is, if you ask them this question, the patient will know that you know what you're talking about, and it will be good for your relationship to the patient because he now sees that you understand his problem. And during coughing, many of the patients, nearly all, will tell you that they do not lose because their striated muscle is intact. Again, if you ask him this question, he knows that you understand his problem. I have had a patient who came to me and said, I went to a different department, to a urologist, and he asked me, can you interrupt your stream? And he said, yes, I can. So he said, you're not incontinent. So this patient, of course, was very disappointed and saw that he was at the wrong place to go. So what more do we have? Of course, these days you want to have a quality of life score, and then you should know, of course, if there is some medical trauma, some medication trauma, neurological diseases. And then again, you want to know the time of onset, because this can be together with some things, some trauma to the urethra that happened after the prostatectomy. So what kind of baseline exams you should do? Of course, the cuff test, as mentioned before. You need to know a PVR, of course, which hardly, just in case there could be a bladder neck stenosis or things like that, and you want to see the uroflow. Cystoscopy can show you bladder neck contraction, the functional length more or less via cystoscopy, but you can also check his voluntary contraction, and it gives you an evidence on what the urethra looks like, especially before you do a PROACT. You should have an idea of that. Then you can also add the repositioning test. This is something you would want to do before you try an advance sling. It is basically a test where you push the perineum, but not upward to close the urethra, but parallel to the urethra to see if there is a concentric close of the sphincter. But I will not go into that too much, because Ricarda is the expert on this and she will show you exactly how it works. But it is important to do this test before you try to do a retropubic sling. Then it is important to have an overall impression of the patient, a psychological status, and to know his expectations. Why? We have certain therapeutic methods and implants that do work, but they do not work on day one. Some of the adjustable systems you have to adjust for 2, 3, 4 months maybe. And if you have a patient who is in a psychological status that he cannot take this, you would have to choose a method where he has a success immediately. I think this is important to know when you choose your method of therapy. The mental status is important because it could be a contraindication to use an AUS. The artificial sphincter really needs a certain mental understanding of the patient and also, of course, the dexterity to use this device. We use a clock face test. I don't know who is familiar with this. Yes. It is really nice. You wouldn't think what you find when you ask the patient. You give them a clock face and ask them to make the two fingers and say, put in 11:15, and you wouldn't believe what you can find, what abstract, interesting pictures you could find here. And then we do simply a ball pen test. In fact, we don't really test it. I ask him, can you take a ball pen apart and put it together again? And you can see from how they move that it will be easy. And if it's not so easy, I have them really detach it on my desk and then put it together. It is important because there is no use if you put in this beautiful but expensive device and after all he can't use it. Maybe the flow secure sphincter that's coming that has a new pump now, which is a little bit bigger, but we haven't had a lot of experience with this implant. So what about urodynamics? Who does urodynamics routinely before male incontinence surgery? Well, I know that it is important for reimbursement in certain countries because it would not be paid otherwise. But normally, how are you doing, Ricarda? You do urodynamics? No. Fly? Yeah, it's
cases with urge symptoms.
right. Yes.
Additional neurological disorders, not in every case.
Yeah, right. So routinely, we also do not do it, but it might be necessary for reimbursement. We discuss it then afterwards. Of course, as we heard, in 3 to 7% of cases, you might have a component of overactive bladder that can be discovered doing this, but you would have to treat the patient anyway with some sort of implant. Now, when do we do the urodynamics? We do it, of course, when the diagnosis really is in doubt. When I'm not sure, is it an OAB wet, or is it not? Then we do it if it is a redo case, if we had some sort of failure to our therapy. And you need it, as I said, it is required in some countries even before the bulking agents. So we don't do it because we don't do bulking agents. We even skipped it in this meeting because I think it's really rarely indicated. And but it may be important before you do a sling or an AUS, especially to assess the bladder function. And again, I'm coming back to the first questions that you put to the patient. It might be necessary to let your patient know that he might be dry after the surgery, but he might have to go to the toilet every hour. And again, you can tell him this will be the case. You might have to go to the toilet very often, but this will improve because it normally does improve when you put in a sphincter or a sling or anything. So it is important to understand that in the vast majority of cases, ISD is the main cause of incontinence. And that the bladder dysfunction hardly ever is of harmful magnitude, but this was also pointed out by Flavio before. What about leak point pressures? The Valsalva and abdominal leak point pressure did not show any correlation with the 24-hour test. But what we do sometimes is the retrograde leak point pressure. The retrograde leak point pressure, as shown here schematically, is the following. We have here the smooth muscle sphincter, and we simply, by a fluid column with a infusion system, we lift it up and down until the dripping comes to a stop. That represents the leak point pressure of the smooth muscle. We learned to do this with adjustable slings mainly, to intraoperatively titrate to the right pressure. But you can also do it in an outpatient setting. Then I would suggest to put on an EMG to rule out any contractions of the pelvic floor. We were not able to show a correlation to the 24-hour pad weight test, but it is important to use it sometimes to understand or to evaluate the function, for instance, of a hydraulic sphincter. And it might show you that the sphincter is not working adequately if there is a leak of the sphincter, but also if there is a fibrosis of the urethra. So we pretty often use it to find out if to evaluate AUS failures. It is a nice thing to do intraoperatively. I don't know how to put on this movie. Can you put it on for me? Okay. This is not working, unfortunately. The point is that what you would see on the movie is that we come down with this bottle, and at some point the dripping stops. That represents this pressure in here. This is an anesthetized patient, so we have ruled out the striated muscle component. We had very good correlations to our results. The point again is that you will find an intravesical pressure first. You put your catheter or your cysto into the bladder, and that should be, of course, below 15 centimeters of water to show that your system is working. Then you do it without the sling, and in an incontinent patient, you will find values from 15 to 25, sometimes even lower than that. And then you adjust the sling up to 25 to 40 centimeters of water, and you will have a very good result on the next day. So these are the nice things. And we sometimes even do it in adjustable slings that can be adjusted later on, like hydraulically adjustable slings. But I personally do this in every surgery because I want to have a quick result for the patient even on the next day. So UPP is not important, and radiologic evaluation mainly in redos, but not on a routine basis. So I still owe you the timing of evaluation, and we wanted to talk about that. Traditionally, it was 12 months after radical prostatectomy and early after TURP, but I believe you can do it earlier. If you have not seen any improvement within 3 months and you see that there's a severe leaking after 3, 4, 5 months, I think you can start to evaluate the patient to know what you will be doing if you want to do something. And then, of course, in this time, you should already have initiated conservative treatment prior to the full evaluation. So in conclusion, I think you should start evaluation at 6 months. History is probably the most important evaluation if you are looking at a certain therapy, because you should already, with the history, rule out certain indications. The role of urodynamics remains controversial depending on the system you're working in, and cystoscopy is always necessary. Thank you. So I think we could discuss the 2 presentations, mine and Flavio's, at this point. Are there any questions here? Please. Flavio, I think that addresses you.
Say again, please.
Irrigation of the sphincter.
Well, it's important. It's not the main factor, but as you know, in surgery with bleeding, when the people put many stitches, you can compromise the irrigation of the sphincter, and it may be a cause.
Yes, please. Would you please use the microphone and tell your name? It's standing in the middle. Thank you.
Good morning. I have 2 patients, post-prostatectomy, urinary incontinence, with severe detrusor overactivity, with reduced bladder capacity. And one of them is using Vesicare and oxybutynin in high doses combined and still have the hyperactivity. I will try to use Botox. But I'm thinking about, I saw in your slide about combined approach with Botox and urinary sphincter. Do you think it's better to test the Botox first or to perform together? What do you know? How do you treat the hyperactivity associated with the sphincter leakage?
In my opinion, you have to find out the different components of this patient. Does he have an obstruction? Is the question. If he has an obstruction, you have to be careful with the Botox. But what we sometimes do is we first take care of the obstruction. That means de-obstruct him, and then take care of the overactive bladder. Because otherwise you might run into a self-cath situation, which is still better than being wet. But is your patient obstructed or not?
No, he had obstruction before, but I have treated him.
Okay. Flavio?
Times, if the patient is completely incontinent, it's very difficult to evaluate the bladder capacity. In these cases, I ask the patients to use a clamp for 2 weeks, and then I will do the evaluation.
Erwin?
It's the only situation that I
Suggestion?
recommend the clamp.
Yeah, I would add something to this. I think it's also in these patients, the urodynamic is useless. Why? Because of what Flavio just mentioned. Bladder is not functioning, hasn't been functioning for a while as a reservoir. And I had this experience from when I was doing kidney transplants. I was still working in Italy at that point, so there's a huge waiting list to do the kidney transplants. So those bladders were not working for years. The life of these patients was miserable the first week, was a little bit better the second week. And after the first month or couple of months, the problem was solved. So it's time is actually, you can use the clamp. The clamp is good for the patient because peanut clamp. Because the patient will know what is going to happen after the activation of the sphincter or after the surgery, and is going to tell you if this overactivity is really the reason for incontinence, which is, in my experience, in a very, very limited number of patients.
Any other question? Yes, please.
Good morning. Oleg Tatrov, University Hospital of Wales. So a couple of questions, please. The first question is, how do you do urodynamics when someone is severely incontinent? And a second question to Professor Rocha, is that correct? Is what's the role of pelvic support mechanism in post-prostatectomy incontinence? There is more information coming forward, and we're now almost comparing post-prostatectomy incontinence with female incontinence when there is a loss of pelvic support. So, so two questions: urodynamics and pelvic support. Thank you.
Any ideas to the urodynamics? Maybe Ricarda?
So you're completely right. In a patient who's really severe incontinent, the urodynamics, the results are very often completely helpless, because there's no bladder capacity. During the urodynamics, the urine flows out. And so in these cases, I used also the penis clamp before. In these cases, I loved the penis clamp to improve the bladder capacity and do the urodynamics later on if it's necessary. And in my opinion, it's not necessary to do urodynamics in every severe case, because very often it has no impact on the decision later on for the surgery. We only do it if the patient has some additional problems. And for me, the urodynamics is important to rule out other reasons for the incontinence. But if the patient is only severe stress incontinent, I don't need the urodynamics, but I like the penis clamp before the artificial sphincter to improve the bladder capacity, so that for the patient it's easier later on after the implantation.
Let me also add something to this point. I think we should come back to our goal. The question is which method to use. It is our decision making, and the question really is, do I need the urodynamics for my decision making? Normally it will be more important to know if the patient can interrupt his stream and is leaking more in the afternoon. So this will make my decision making more clear. And then, yes, urodynamics can be necessary to find out what he will experience after we have done a successful surgery.
Regarding the urodynamic, I always do the urodynamics when I'm going to do a surgery, because I want to tell the patient how he's going to avoid and so on. And I really want to evaluate the bladder component. Another thing besides urodynamic, it's the urinary pattern during the night. Many of these patients, they don't leak during the night. So if he tells me that he stays 3 hours without going to the bathroom, I can tell him, well, you are again a good candidate to stay such time. Regarding the ligaments, I think the ligaments, they have a main role in recovering in the time of recovering incontinence. And you can see that in robotic surgery. If you do the Rocco maneuver, you reduce some part of the ligaments, the patient will recover continence sooner than if you do not do.
Okay. Last one, please. If there are some burning questions, we can definitely go into them a little bit later, but right now then we have to go on so we stay on time. Please.
Okay, thank you. Only one important aspect about the defunctionalized bladder that Dr. Ervin said now is that we have a paper in this segment too, that the bladder recover, it takes more than 2 weeks. So if you use the clamp, it should be a longer time, because 2 weeks is not necessary to improve the detrusor contractility, neither to check the detrusor hyperactivity. Most papers, some papers that are in the subjects tells about 2, maybe 3 months, and the complete recovery may take 6 months. So it's controversial too, in our opinion.
So I use the penis clamp at least 5 to 6 weeks. Perfect. Before re-evaluation.
Yeah, okay.
And the reason why I'm using the penis clamp is to let the patient know what is going to happen after the surgery, so they can manage better their expectation.
Yes,
Okay.
in all of these papers of renal transplantation, the total time is about 6 months. But in 2 weeks to 1 month, you have a very good tendency. If the bladder is stable, it's not going to improve. But if it's improving, it's probably is going to recover after some months.
Very good. So thank you for this discussion. Now we move on.